Good afternoon or evening, fellow Foreign Ones. Today we are back with another Zoom virtual town hall, and we are going to be talking about GST deployments. Today we have joining us Sergeant Frost and Sergeant Long, who both are on GST teams. And I'm going to go ahead and hand it off to you, Sergeant Frost. You can go ahead whenever you're ready.
All right, I'll go ahead and start with introductions. My name is Staff Sergeant Justin Frost. I've been in the Air Force for a little over 5 years, and I'm currently stationed at Wright-Patterson Air Force Base. Sergeant Long, you want to go ahead? There we go.
Yeah. My name is Staff Sergeant Aaron Long. I've been in for right about 9 years. I'm currently stationed at Nellis Air Force Base, and I've deployed twice, once as the MFAST ECAT, which was the forerunner to the GST, and then recently again as a GST.
And simply put, a GST is a 6-person team, and your main mission is to be able to go out in the field and kind of create a new med ring. It's to do austere surgery. So you could be doing surgery anywhere from like a mud hut in Afghanistan to like a shipping container. I think the rule is pretty much you just need 3 walls. There's 3 members on the team. You'll have like a general surgeon, anesthesiologist or a CRNA, ER physician, ICU nurse, and an MSC, which can either be an officer enlisted, and then the most important member, of course, which is the surgical tech. As far as training goes, I'll let Sergeant Long take that. He's attended most recently.
Yeah, so in terms of training, what you're going to do is once you have been selected, you're going to go to the GST course, which is a phase 1 and a phase 2. The first phase is out of Wright-Patterson Air Force Base. It's 2 weeks didactic and then hands-on. So what you're going to do is you will spend the first part of the morning going over the emergency war surgery book and lessons from various SMEs in the field that relate to you. So there will be a general surgeon that leads the class, ICU nurse, ER doc, a surgeon, another scrub tech, and they will talk about your role in the field and how it all works out and getting you used to damage control surgery, because this is not like it is during like in a level 1 trauma center when you have all of these resources. You have to learn to get outside that box of thinking. You have a very finite amount of resources, and you're just there to stop the bleeding, start the breathing, and move the person onto the next echelon of care. So you do that, and you get to work with mannequins, and it's a fantastic simulation. The instructors work very, very hard to make it as realistic as possible, and you get exposed to the bag sets, which is what your equipment and supplies are in. They're very, very large duffel bags with everything tucked inside, and you learn how to operate out of that. And then the second phase of the training is you have this foundation, then you go to Camp Bullis, and you do your EMEDS training, and that gets you used to the conventional setting. And then at the end of that training there, you do some specialized GST training where you get more live patient models for you specifically to work on. And there's a great deal of instructors that have worked in the SOF community that come together to teach you, mentor you, and stress you so you can perform in these high stress situations. After you go to your GST training, now, like Sergeant Frost said, you were stationed in very austere environments, so you go to fieldcraft, either hostile or unconventional, where you learn more of the tactical aspects of your job. You carry a weapon all day long, and you do land nav, combatives, weapons, and things of that nature, counter IED. And then for those who may get selected to go to Africa, in addition to that training, then you go to what's called ECAC. And the best way I can describe that is SEER light, because you go to these very, very austere places. There's a higher risk that perhaps you might be captured or detained. So the Air Force prepares you for that. The SME that some of you may want to reach out to is Staff Sergeant Joseph LaSalvia. He's been to Africa, and he's gone through ECAC. So if there's questions about that, he can speak on that. I haven't personally gone through that.
Yeah, thank you, Sergeant Long. As far as the workload will go, that's going to depend on where you're stationed at. I've heard stories from folks who went to Africa, and I mean, you're still the only surgical, component out there, but you might not get any patients, if, maybe just a couple. I know in Afghanistan for the missions we were doing, I mean, you're still the only surgical capability, so you're on call 24/7, from 6 to 7 months straight, but you're not getting patients all the time. I mean, on average, at the one place we were at, it'd be, probably 2 or 3 casualties a month. And I mean, think by the end of it, after all the missions, everywhere we went, we had just under 40 casualties. But out of that 40, I'd say probably less than 10 actually required, like surgery, like an X-lab. We did a couple X-labs, clamshell thoracotomy, a couple X-fixes, did some vascular stuff. So, I mean, a lot of those patients are just going to be, your doc will throw in a chest tube, you resuscitate them, fluid resuscitation, get that blood in there. They get better, you send them on to the roll 3. I mean, that's kind of the great part about the whole GST mission. You're kind of doing that, I don't want to say the bare minimum, but you're doing what's necessary to get that patient to survive, to get to that next point or role of care. And then what to expect as far as when you go out there. I mean, again, that depends on where you're going to be at. I know a reoccurring thing I've been hearing from people, no matter where you go, is supplies. So order ahead, because there was stuff that the team that we replaced ordered was like showing up, 2 or 3 months after they left. So literally as soon as I got there, I hopped on, ordered stuff I thought we would need. You got to plan ahead. So I ordered, more laps, some more split drapes, some more, disposable 10 blades, all that kind of stuff. You really have to plan ahead, because if you do run low, you're going to be calling around to all the other, roll 2s, roll 3s, pretty much, beg, borrow, and stealing, as many supplies as you can, which we did have to do on some occasions. Also, a big thing, at least for me, was the med planners will sometimes really kind of undersell the type of missions you go on. So I would see, if possible, if you can contact folks, where you're going on like a GST mission, guys who are actually on the ground, because there are a lot of times you'd be told that, this is just going to be a training mission. It's like an 8-day thing. And then we go and we're going to the pre-brief the day before the mission, and they're saying, well, you're going to be supporting 300, Afghan commandos as they clear a bunch of villages. And then, oh yeah, directly north of your position, there's a estimated 300 Taliban fighters. So, that's definitely going to change the type of supplies and bags, how many bags, you talk about in the training, how many bags you're going to take. Because we did not bring all, I think it's 12 or 13 bags. I think we brought like, 5 or 6. So we were not, luckily, what ended up, nothing ended up really happening. The Taliban ran off once we infilled. But that could have been, really bad. We would not have been ready for that kind of situation. Or, another mission we went on, they told us, there's nothing going on. So we didn't really bring that many bags. And we get there and talk to the kind of like ground commander. He's like, can you guys get, another kind of litter? Because, there's been 2 mass cows since I've been here. So, and then sure enough, I think we had a mass cow like 2 weeks after that. So definitely try and, if you can, contact the boots on the ground to kind of give you a better understanding of how to prepare for, the missions you might go on.
And to kind of piggyback on that, what he said is absolutely correct. And the other thing is, you want to know the ground commanders are good at their job, and they absolutely depend on you to be that force multiplier, and they're willing to take the necessary manageable risks because they understand that you guys, as the surgical team members, are there to take care of their guys if there's injuries. Now, on that note, you can't, in addition to underselling and overselling yourself, you absolutely have to know what your mission capabilities are and what you can actually do. There was one point that it was when I was in Syria, as far as it was determined whether we were going to airlift out of the area we were in, or we were going to G-lock or ground convoy. The team master sergeant came to me and said, hey, what can you guys do in terms of the convoy gets hit on the way to the location? And I just had to keep it short and sweet, but also understand that, well, yes, we could technically do surgery, but you want to get off the X as soon as possible. It may have been more beneficial in a hypothetical case for my physicians, ER doc, ICU, work with the 18 deltas. If someone had been injured, stabilize that patient, call in a helo, and get them out, because in some cases you may do more harm than good trying to do surgery in the back of a truck if you don't have to, and you can get that person on a burden out. So when you're talking to the combatant commanders, when you guys get over there, you go to your briefings, make sure you absolutely understand your mission set, and then don't oversell yourself to those individuals. I mean, undersell yourself, but make sure the commanders understand what your capabilities are.
All right, thank you. And then, I mean, as far as being on a GST, I mean, that was probably the highlight of my Air Force career. I mean, I loved it. I mean, the only thing I really disliked about it was, I mean, by the end, you're kind of a little burned out. That's kind of how I felt at the end. You know, you're definitely, I think that's any deployment. Everybody will tell you that you're ready to come home. So, I mean, how'd you like it, Sergeant Long?
You took the words right out of my mouth. I would say absolutely the highlight of my career. Go back and do it again in a heartbeat. You actually get, you know, sometimes, like when I was a young airman, I struggled with what exactly my purpose was and how I fit into the big picture. And when you get out there, you get into the field, you get to see the guys that you're supporting and how you fit into that. Absolutely. It's a fantastic feeling. You get to see the big Air Force picture, not just your little section at an MTF.
And as far as what I wish I would have known, I mean, trauma's not as scary as it sounds. You know, I was kind of terrified. You know, I'd never done, you know, any kind of trauma surgery before. So mostly just talk to your surgeon, talk to your doc, definitely start to kind of build that rapport. So, I mean, he put it very simply for me. He's like, everyone, you know, turns trauma into this big thing. Simply put, all right, we need to stop the red stuff from coming out and put more red stuff in, right? I mean, ultimately, that's what it comes down to. You know, it's not as big and bad as scary. What I used to do to help me is I would make kind of my own little, like, you have like the P kits. I'd kind of make my own, they call them the P packs when you go through training. I would kind of make my own packs to kind of help me out to where, and I'd even write on it. I'd have ones for like, if we did chest or ones if we did abdominal, I'd even write that on the bag. I'd put chest and abdominal. I'd put all the supplies in there that I would need if that type of casualty came in. And that way I could start setting it up. And like, let's say there's an arm, we'd always have like an army mech, like, hey, can you start opening this stuff up on my back table while I get ready? Start grabbing sets. That helped me a ton as far as getting ready and everything like that. Some type of stuff I wish I would have done more of would probably be, you know, if you have vascular surgery, wherever you're working at, definitely hit that up. Ortho, if there's any X-fixes, that kinds of stuff. If possible, definitely try and attend the SMART program or C-STARS. I highly recommend all those types of things.
Yeah, same thing. He hit the nail right on the head there. Things that I might have done to better prepare. There's a couple of books I read while I was out there. Sergeant Frost and I know them pretty well. You can get them, you know, they're relatively inexpensive. And also for anyone who doesn't know, there's a DOD, it's run by the Army. There's a free book program. You get like one free book a year. So you can request some of the medical texts that are out there. But I would highly recommend reading Top Knife. It's an introduction to trauma surgery written by a trauma surgeon. It's breaks it down. It's a wonderful book. And then I've got Pictures Worth 1,000 Words. This is one book that Sergeant Frost and I read while we were out there. That's the Emergency War Surgery Guide. This is also what they teach out of at the first GST course. It's written at the technician level. We can all understand. And then its companion book is the War Surgery Afghanistan and Iraq. And it's a case of basically big case reports on most of the things that you could possibly see and be exposed to. So, you know, like G.I. Joe used to say, knowing is half the battle. You know, the more you know, and you talk to your surgeon, and they love to teach, your ER physician, ICU nurse, if there's anything that you don't know, by all means ask. And a lot of the time, they'll ask you questions as well. And like Sergeant Frost said, where I had the PPACs and everything, where I was embedded, we actually had a schoolhouse. There were some shelves and whatnot. And what I went through one night is I organized them all in terms of like stages of the surgery, just kind of like when you go into your OR rooms and your MTFs, you know, you open it up and it's like, there's lap sponges here and towels and Bovie tips and chest tubes and things like that. I categorized and organized all the cubby holes. So all I had to do was turn around and get something, or be able to tell someone exactly where someone was. And that helped me significantly because I can control that. I know where everything is, and I can tell people to get it, or if I need to get it in a hurry. So.
Cool. And then as far as how to get yourself on a GST, I mean, that's going to be a matter of, talking to either your flight chief or your functional. I mean, it's really, you just got to put it out there and, let your leadership know, hey, I really want to do this. Also, one thing I wanted to mention too is if you're interested, make sure you talk to members in your own flight who have deployed. I did that. I talked to Sergeant Long before I left, asking him a bunch of questions. I also think Sergeant Bridges and a couple other people, just trying to get what their experience was and kind of trying to figure out, what worked for them, and just, all the advice on, what to expect, because if you've never done it before, you have no idea really what to expect.
Absolutely. And if I was going again, if I was going to Afghanistan, I'd be talking to Sergeant Frost, because that's another thing is, compared from my first deployment to my second deployment, there were definitely things that were similar, but after Sergeant Frost and I compared notes, there were a lot of things that were similar, but also there were a lot of things that were different. And so it's great to ask everyone, because the way the combatant commanders use the ground surgical teams, one deployment in a certain location like Africa may be completely different from like Sergeant Frost's deployment in Afghanistan. And Sergeant Frost was telling me how you have these big duffel bags or whatever, and in training, they, in addition to trying to get you to think outside the box, they also say, oh, hey, it's like they train you to, it's like you can take X number of these duffel bags and so on and so forth. In Sergeant Frost's case, he was telling me about how the Army is like, well, you actually only get a couple of Pelican boxes and you got to use that. So you have to really learn to think outside the box. So the more people that you talk to about deployed before, the bigger your knowledge base and the better prepared you will be. And absolutely talk to all your senior NCOs that were there when in Iraq and Afghanistan was really, really hopping, because all that information that they have is absolutely invaluable.
All right, cool. And if there's no one has anything more to add, we could leave the floor open for any questions.
I see Jay asked a question. I'll answer that for mine. You asked about how EMEDS was. I thought the second time I enjoyed EMEDS significantly more than the first time, and the effort and expense that's been put forward with the increase in LPMs has been fantastic. The fact that we get to use that to the nth degree to learn and do scenarios and practice procedures on, hands down, that is fantastic. Additional training, I thought of two things. One, I think it would be fantastic if the scrub techs could get more basic EMT type training. I think that would be really, really good as well. Also, in the event that we were going to, my team was going to have to G-lock out, there's a portion of Fieldcraft specifically they use it for logistics personnel, people that drive convoys. That is given to us, and when that event happened, we were going to kind of have to do it on the fly and learn as we go. I think if we were to get that trained as well, that would be fantastic, because you never know, what we're going to have to do. And the idea of riding the convoy and having to drive and be part of that without that kind of foundation, that's very intimidating. So I would like training like that as well.
Yeah, I 100% agree with Sergeant Long. I think Sergeant Long and I even had this conversation before about, just wishing I got more of that kind of, that 4-0 training, just to make me that much more of a force multiplier. Like, we learned how to do IVs, but I mean, I never did one, because every time there was someone there who, did them more often, so it made more sense for them to do it. They're going to do a better job than I was. So I wish there's something, maybe if it was just, 2 to 3 weeks where you go, even maybe in your own MTF, just shadow, some of the 4-0s like in the ER and ICU, just to get a better idea of, how they do their job. I saw a question here. Can shreds be put on a GST? Yes, they can. I know of Orthotech who's currently on a GST right now.
I'd add one more thing. This is kind of a caveat to some of those out there. When you deploy, Sergeant Frost, myself, both had this experience. You're going to go through training. If you're not familiar with firearms, and let's say you know someone in your unit that is, try to at least get a little bit of a base foundation. Now, obviously, you will be taught at Fieldcraft and imparted EMEDs, safe handling procedures, how to utilize your weapon correctly, how to clean it, how it functions, so on and so forth. But if you can get a little bit of a base foundation there before you go to those things, to be comfortable around them, because there is a very good chance you'll be strapped your entire time there, makes it better.
If you get put on a GST, are you always on a GST? The answer kind of is yes, unless you PCS or kind of something like along those terms, you're technically still in that. I think was it the code? I'm not sure. I can't remember.
We're coded, after you go through the training, we're coded for life now.
Yeah, you're coded for life. I think your training's good for, quote me if I'm wrong on this, I think every 2 years.
Yeah.
You have to go. So
yeah, because Sergeant Kaloides was able to go on his most recent deployment. He had to go to the GST course with everyone, but I want to say there was some training he was able to ellipse because it was still current. So
gotcha. I just found a question. What was your opinion of the training provided at EMEDS? I think when I went, it was 2018, and I really enjoyed it. I mean, I thought it was pretty cool. It was like kind of get to see the whole big picture as far as, how the GST and like the EMEDS kind of work together. So that was pretty cool, seeing everybody working as a team. How about you, Sergeant Long?
I thought the training both times was really good, and especially if you've never been in a field hospital type setting, I think EMEDS really does a good job, because it gets you out of the clean, sanitary, first class facilities we have here in the States. And even if it's, it's a tent, but the places we were at, that's essentially what you do is you set up your from your true and your receiving all the way to the operating room and then a recovery area. It's basically the same. You're using the same field stanchions. You might have hardened, not facilities, but at least hardened walls and a hardened roof, but you're still using the same litter stanchions. You're still sterilizing and disinfecting the instruments like you were taught at EMEDS. It's the same environment. And so getting exposed to that was absolutely worth it. It was great.
All right, well, if there's no other questions, I think we're going to hand it back to Tech Sergeant Kaloides.
All right, thank you guys. I'm actually going to hand it over to our CFM, Sergeant Har, for any input that he may have. Sergeant Har, go ahead whenever you're ready.
Can you guys hear me?
Yes, sir.
All right. Awesome. Thanks, Sergeant Long. Thanks, Sergeant Frost, for your word, for informing us on what you guys experienced with the ground surgical team. And I just wanted to kind of piggyback on some of the things that you guys covered. That yes, it would be ideal for the 4-in-1s to learn some other skill sets that will prepare them for, a deployment, because the majority of the GSTs, you're not engaged all the time in doing surgeries. Being able to do some sort of interventions, and being able to uh, kind of do the things that are being taught in TCCC point of injury are important. I highly encourage any tech that is going to be tasked for GST to, at the minimum, get out of your comfort zone. For the most part, cases, so that should be an issue. Maybe help with recovering, intubating patients. I know Sergeant Frost and I think Sergeant Lombo covered as far as starting IVs, drawing blood, some other skill sets that you need to learn, whether it's what some of our counterparts, the 4-0 community, but also if you're at a location where the team is coming from, whether it's Eglin or Right Pat, that you get with the anesthesia provider and the general surgeon to kind of help you bring where you may have to do something different than your typical 4-1 duties, that you're competent and confident in doing those things, practicing starting IVs, taking blood pressure, manual blood pressure. Those are small little skill sets that it will help with the ground surgical team, but also to be able to work outside of the OR, whether it's in a clinic setting, general surgery clinic, because not every 4-1 gets opportunities to do that. Early in my career, I was actually in charge of ambulatory surgical units, so I learned those skills: how to take blood pressure, how to draw blood, start IVs, do EKGs. So I encourage any member that is going to be assigned to a GST that they talk to their leadership to learn some of those other skill sets that would benefit. And I know these guys mentioned as well as really what it boils down to as a surgical tech, you got to think outside the box. Some of those scenarios that are thrown at you may be out at Camp Bullis when you do the GST phase 2 training. But I encourage you guys to start thinking, how else would I be able to clean instrumentation, whether I have that capability or not. If you got some water, sterile water or distilled water, and you have instrumentation that you need to clean, I mean, the least you could do is at least boil the instrumentation if you can, if that's all you have available. Some locations have tabletop sterilizers, which you get exposed to that in EMEDs, or you may have Big Bertha. I really don't know. I don't really have the data to really support that, but just understand that you're not always going to be in a fixed facility in a perfect setting like Sergeant Long would mention. So understand, start thinking of those things. How can I try to at least try my best to clean the instrument as much as possible, so the next time we use those instruments that hopefully we're not transmitting anything and cleaning those instruments as much as possible. But anyway, just going back to the skill sets, being able to do things outside of your comfort zone, that I definitely would encourage people to do that. And I think they also cover weapons training. That's something that, if you don't own a weapon or never dealt with weapons before, I would highly encourage you to have somebody teach you a little bit more, so you're not looking, be that awkward person that, doesn't want to be able to carry a weapon, but also you have to, your assets, your personnel, if you ever have to engage and potentially, have to use those skills to be able to use a weapon. So definitely thank you guys for sharing your experiences and just giving a little bit of a peek of what these guys, whoever gets assigned to the ground surgical team, may experience. It's not just surgery. So thank you for sharing that information. And my goal as the curriculum manager is try to find, some sort of training platform, or at least identify some of those consistent things that people are doing with the GST that is not really captured in TCCC, that's not being taught in GST phase 1 or GST phase 2.
Sergeant Hart, can you talk a little bit about if you're on a GST?
Would at least bridge the gap to be able to not be Can you hear me? What was the question? Sorry,
I
Floyd?
can't hear you. I'm sorry, you're cutting out. Can you talk a little bit about the possibility of not deploying with the team that you might be assigned to, like even being on a GST, you know, that you could potentially assign or deploy with a unit that's not necessarily your team?
Yeah, so there's opportunities where the ideal, when the team was first created a few years back, 4 or 5 years, the intent was to have everybody train from the same location, but things change, right? There's things happen with different individuals within the team dynamics where you may not have the same general surgeon that you train with, whether they already deployed or there's somebody else that's available that can fill in that spot. So that's not always going to happen where you have the same team from one base. You may have a general surgeon from one base, anesthesia from another, and the rest of the group from one base. So just you know, understand and be flexible that you know, you may not have that team dynamics like you would with other teams who, when they first started, did training from beginning to end and deployed as a team. So be understanding that that could potentially happen of being broken up from different bases. The other thing that was kind of mentioned is you know, can shreds deploy as GST? And I think Sergeant Frost mentioned it. He was here at Nellis, and we did deploy 2 orthopedic techs on the team. It's based on whoever that MTF functional manager. If they don't have the bodies, the 7 levels slicks to deploy, then you can dip into those shreds. You just got to be understanding of what that mission capability will be for the clinics. Would the OR have to support since you're sending a shred, you know, on a typically a slick position? So you just got to be understanding to that and making sure that your leadership is able to be on board with sending ENT, urology, or ortho tech for a GST. I am working with the pilot unit for the GST, making it a potential substitute without having to do a waiver. Because right now, at the moment, your readiness would require some sort of waiver to say, are you willing to use a specialty tech for a GST? And then try to remember, so going back to providing a training platform, I'm working to figure out a training platform to kind of bridge the gap and give OR techs before they deploy in a GST a little more training than, you know, your typical surgical, which you should be familiar to doing that. So I'm working on that. My goal is to have something set, hopefully sometime next year, a course that would definitely benefit and will be value added to the OR techs that would be assigned to a GST and deploying downrange. Did that kind of answer some of your question?
It did. Thank you, sir.
Yeah. And that's all I have, guys. Thank you for dialing in, and thank you for you know, taking time out of your busy schedule to provide this amazing feedback about what exactly does it mean to be on a GST and deploy.
All right. Thank you, everybody, for logging in. And if you're watching the replay, we appreciate that too. Our next session is going to be on Wednesday, September 30th. We're going to keep the same time, 1700 Central, because consistency is best. We're going to be going over the C-STAR/phase 1 of GST. I know they covered a little bit here, but we'll get a little bit more in depth with the instructors that are currently there. So I hope to see you next time. Thank you, guys.